Welcome everybody. We're going to get a chance to talk about these guidelines a little bit today. I have no disclosures. So when you look at the ASA guidelines, the reason I have this slide up here, there are actually 8 different recommendations that we make in those guidelines. But if you look at recommendation number 3, it's really the only one you need to know. So everything else is supportive of recommendation number 3, which says when using quantitative monitoring, we recommend confirming a train flow ratio greater than or equal to 0.9 prior to extubation. Here's the rest of them. And so looking at this, the first guideline is again supporting that, saying you should not use clinical assessment. Second recommendation says that quantitative monitoring is preferred over qualitative monitoring, which is why we recommend a train flow ratio of 0.9. It's the only way you can get that is with quantitative monitoring. And then recommendation number 4 is saying this is the muscle that you should use. It's the one that has been studied the most, which is the adductor pollicis. We then say recommend the second against recommendation is to not use the eye muscles because we know those are relatively resistant to neuromuscular blockade. And then we get into some suggestions on reversal, saying sugammadex is preferred at deeper levels of block, neostigmine is reasonable at minimal levels of block, and that when you're using benzoyl-isoquinolones, you need to use neostigmine. And you can see down there, the top 6 recommendations there are strong recommendations supported by moderate level of evidence. The second 2, the 7 and 8, are conditional recommendations supported by low level of evidence or low strength of evidence. So how do these come about? We have different options for publishing at the ASA. We have standards, we have practice guidelines, which is what I just went over. We have practice advisories, statements, and expert consensus documents. The one that we went over, it's really all this is overseen by the ASA Committee on Practice Parameters. And then for guidelines especially, last year was a really big year for us on the neuromuscular blocker guideline because we have to go through the House of Delegates and they have to be actually voted in, okay? They are not the level of a standard yet, okay? You can ignore guidelines if you want to, but it's a very rigorous process to go through. It was 2 years of research. It was coming up with the paper. It was getting accepted in anesthesiology. It was then getting it into the House and accepted at the House of Delegates. So a very long, drawn-out process, which Dr. Domino made sure that we were very focused on this being an evidence-based guideline. Despite all that, not everybody loves it. And here are the reasons why we did it, though. There's a long history, many years, decades of neuromuscular blocker research suggesting that there are better ways to do this than what we were doing. We've had the Anesthesia Patient Safety Foundation recommend that we should make guidelines. We've had anesthesiologists in America coming up with an ANA in 2018, writing a guideline, a consensus statement actually, saying, hey, we need to talk about this. We need to come up with better ways to manage neuromuscular blockers. And then other countries, we're actually pretty late to the party, and I'll show you on the next slide just how late we are. And then again, I give a lot of credit to Dr. Domino. She took over as chair of the Committee on Practice Parameters, and it was with her leadership that we actually pushed forward with this topic, which again, it was overdue, but it wasn't particularly popular because not everybody wants to change practice, which is something we definitely recommend. So here we are. So who were we behind? Who beat us? European Society of Anesthesiology and Intensive Care, theirs was only by about a month. They published theirs in December of 22, I think. But then the Canadian Anesthesiologist Society, the French Society, the Spanish Society, Australian and New Zealand, Italian, Czech, Portuguese, they all come up with guidelines. And these guidelines are really consistent with regard to advocating for quantitative monitoring. And in particular, the European Society of guidelines, there was an editorial that came out on that recently showing just how similar our 2 guidelines were. Theirs is a little broader in scope, but where ours overlapped, it was almost as if we were plagiarizing one another, when in fact these were 2 committees that didn't even talk. We didn't have anything to do with either one of us researching literature or coming up with our guidelines. So pretty reinforcing when you look across all the guidelines to see how consistent they are across the world. So these guidelines, though, if you read the guidelines carefully, you're going to notice that everything just talks about incidence of residual paralysis. So do this, do that, so you can reduce residual paralysis in practice. So I get a lot of feedback from people saying, so what? I can reduce residual paralysis, but that's not what helps patients. What helps patients is showing that there's improved outcomes. How come you guys didn't talk about improved outcomes? There's a reason we didn't. It's because you can't consolidate all that information into what's essentially a mini meta-analysis, which is what our statistician did throughout these guidelines. But because in all these studies they used different monitors, they used different cutoffs, they had different outcomes, you can't consolidate that information into something that's very strongly literature-based for a recommendation in the guideline. However, that being said, I want to make you aware that there are studies out there. There's 26 of them that I'm going to show you in just a second, from 1997 to 2022. And you'll see there's various technologies as well as various cutoffs, though it all circles around and is close to the 0.9 train-to-4 ratio, which is why we use that in our recommendation. Of those 26 studies, the different technologies used, there's acceleromeography, in which, that was loud, sorry. 14 of them use acceleromeography. 6 of them use mechanomyography, which is the reference standard, okay? It's not electromyography yet. It remains mechanomyography. I'm not allowed to use the word gold standard because our statistician said that's not technically correct, so that's why I say reference standard. And then 5 of the studies are electromyography, and then 1 is kinemyography. And this, I know it's a busy slide, but I'll just show you, here you got the top 3 are A and G. And the kind of outcomes that have been found there are PACU length of stay is longer with residual paralysis. Recovery quality is diminished with residual paralysis. Patients feel more weak. They have reduced force vital capacity. Their peak expiratory flow is reduced. They have more incidence of hypoxia. There are more critical respiratory events. There's more often respiratory failure. Postoperatively, they have more upper airway obstruction. You have more post-op critical respiratory events. Pulmonary complications can be increased, and hospital length of stay is also increased. I'm not saying this happens for every single patient, but I'm telling you this is what happens more often in the patients who suffer from partial paralysis, which is a train-to-4 ratio less than 0.9. We also have, the next line there, post-op pulmonary complications, visual abnormalities. They have trouble speaking, swallowing, more weakness, more hypoxia, more PACU length of stay, more airway obstruction, more critical respiratory events, and it goes on and on. So these are the studies. You can see down there, I've actually listed all the studies. If you want to know what the specific study is for each one of those outcomes or for that collection of outcomes, I have them listed down there to make it easy for you to look at that and to understand that this has been looked at. There are patient outcomes, and residual paralysis is problematic to the patients, even if we don't notice it, which is kind of the biggest problem here. We drop them off in the PACU, we turn our backs, we go back to the next case. We don't actually get to see what's happening, and that's when we have to rely on the evidence. We have to look at the people who have looked at these longer-term outcomes and discovered that there is a difference in patients who are partially paralyzed versus those who are not. So this is what it looks like in the guidelines, though. So what I'm showing you here is what's called a league table, and what that is this is that meta-analysis sort of analysis that I was talking about with our statistician. How this works is you have a line there, quantitative, which is going to go across the top row and the first column. Qualitative is the second row, second column. Clinical signs is the third row and the third column. And where those two intersect is where they compare. So what I have written out there is qualitative assessment versus quantitative. And what this is the relative risk of residual paralysis if you use quantitative monitoring versus qualitative. So relative risk is 0.34 or 0.36, depending on whether it's a network analysis or direct analysis. Unfortunately, I put those in the wrong place. That little parentheses network should be where the direct is, and the direct should be the other way. The direct is the upper right, the network is the lower left. But the point here is that you have a very significant reduction in the relative risk of residual paralysis if you use quantitative monitoring over qualitative monitoring, which is peripheral nerve stimulator with the visual or tactile assessment. If you look at clinical, it's even more profound, 0.81 and 0.15. I showed you that the patient outcomes were, the reduction or the improved patient outcomes, the differences in patient outcomes were across all different types of monitoring modalities. That being said, they're not all the same. In particular, acceleromeography tends to exaggerate the train-to-4 ratio at the higher levels. So the question is, should a train-to-4 ratio of 0.9 be used for acceleromeography, or should a different ratio, a higher ratio, be our cutoff? So here, what I have are the biases or the differences between the reference standard, which is mechanomyography, and the different other options, okay? So with EMG, it's only one study, but the bias there is 0.47, which I think I have on the next slide, yeah. Meaning that the ratios for electromyography are actually a little bit lower than the comparable ratios in mechanomyography. For AMG, as I've already alluded to, the ratios are actually a little bit higher. There's quite a range though. You can see at 0.08, which means it's lower, versus 0.12, which is about 10% higher. So there's a bit of a range there depending on which study you're looking at. And then the TOF cuff, which is that blood pressure cuff that measures a volumetric measurement of muscle. That bias is a little bit higher at 0.47, 0.05. So here, I put it together. These are the actual, so the bias, transfer ratio bias is the study and what the bias came up with on those specific studies. And then I came up with that column to the right, which I really feel obligated here to tell you that the statistician told me I can't do this. So he's very opposed to me showing you guys what the new cutoff would be. So Mark Grant has totally absolved himself from what I'm talking about. But for me, that's what's important. Like, how am I going to change my practice? If these things are different, what does that mean for me? Do I need to have a different train of four ratio? So in particular, when I look at AMG, I'm not advocating for train of four ratio of 0.85 for EMG, by the way, because I think there's way too little data on that. But for AMG, you can see that if I were to convert this to a new train of four ratio, it would be somewhere between 0.95 and 0.99. Many experts honestly recommend a transfer ratio greater than 1 or greater than or equal to 1 for AMG. Okay, I think that might be overstating it a little bit. Here's another reason why I think that. Besides the bias is I look at this paper, Popular. So Popular was a study that showed using neuromuscular blockade was associated with higher pulmonary complications. And in their sub-analysis in that, they looked at quantitative monitoring. And in the initial paper, they said quantitative monitoring actually didn't help. You didn't have reduced pulmonary complications if you were using quantitative monitoring. But then Blobner did a reevaluation and said, okay, the neuromuscular blockade community is not too happy about this result. Let's see if there's something going on. Maybe it was the cutoff. Maybe we shouldn't have been using 0.9 for these non-normalized AMG values. And so he started looking at that. And there's some interesting things about this. First of all, that first bullet point there, when they looked at this, they showed that many of the patients in the Popular study were actually extubated with transfer ratio less than 0.9. And the reason that like 30% of them, the reason I bring that up is because I really want to reiterate to everybody that a monitor doesn't change anything if you ignore it. Okay, if you see a transfer ratio that's 0.6, 0.7, and you think, well, I've done everything right, and you pull the tube, you haven't done anything. So it only tells you what's going on. If you don't react to it, there's no difference. So that's part of the problem with this study, was that people were looking at patients, seeing that they were inadequately reversed and extubating anyway. But then when they looked at pulmonary complications, they have that graph to the right there with the confidence interval. So the big blue line is the post-op pulmonary complications. The small blue lines are the confidence intervals, and that red line is indicating to you that at 0.92, transfer ratio of 0.92 is when pulmonary complications were actually reduced in the Popular study cohort. So maybe that was the problem. So another indication that perhaps raw values of AMG should be elevated above 0.90. So my recommendation, when I put all this together, okay, and I'm also thinking about those outcome studies, which almost all use 0.90, some of them use 1. But when I put that all together, I think, in my practice at least, I use 0.95 as the cutoff for AMG. So if I come in there and my resident shows me transfer ratio 0.9, they're going to extubate, I tell them I'm not impressed, we need to fix that. If it's 0.95, then we're good to go. And higher, we're even happier. That's it. Thanks.